Right, we shall get going. Good evening, everybody, and welcome to another Macular Society, My Macular and Me webinar. If this is your very first one, then you are especially welcome, and I hope that you enjoy and find this evening very useful and interesting. My name's Cathy Yelf. I'm the Chief Executive of the Macular Society, and we've been running these webinars now since the height of lockdown, originally just as a stopgap for the face-to-face events that we like to hold around the country. But in fact, these have been so popular that we shall probably keep them going now for ever and a day. So welcome and thank you for joining us. Tonight, we're going to be talking about Vabysmo. Now, that is something that does rather sound like something that one explains while waving a magic wand, but it is actually the brand name of a new drug to treat wet age-related macular degeneration and diabetic macular edema, two important and very prevalent retinal diseases. The generic name of this drug is Faricimab, and it's a product from a company called Roche, and it works in a similar way to the drugs that are already on the market for DMO and AMD, wet AMD. Those are, for example, Lucentis and Eylea. So it is similar. There are lots of similarities. So what is the fuss about Vabysmo? I am very pleased to welcome somebody who has been very closely involved in the trials of Vabysmo and who can explain all this to us. So welcome to Professor Pearce, a consultant ophthalmologist at the St Paul's Eye Unit in Liverpool. And he's been the principal or chief investigator on very many clinical trials over the years that are looking at the efficacy of new and novel treatments for eye disease, and among them the trials that he's been involved in are the trials for Vabysmo. So Ian, a very warm welcome to My Macular and Me. Let me tell you, Ian is currently on holiday in Cornwall, and he's currently sitting in his camper van in the car park of Truro Hospital, where he is borrowing their Wi-Fi to make sure that he can actually connect with us on the internet this evening. Ian, thank you so much for giving up your precious holiday time to talk to us this evening. I'm going to hand straight over to you to tell us all about Faricimab. Ian, thank you very much.
Thank you very much, Cathy, for that kind introduction. For everybody who's listening, I am on holiday in Cornwall at the moment, and you might say, well, you know, why have I done this on a Tuesday evening? Why didn't I pick a different day? And it was because I got an invite from the Macular Society, and I'm delighted to be able to help in any way I can for two specific reasons. One, the Macular Society have been very, very influential in making sure that treatments for age-related macular degeneration and for diabetic macular edema are brought to market through the influence and explaining to parliamentarians about the importance of eye health. They've been able to push treatments forward which we may not have been able to have, and that makes it better for patients, but it makes my job a lot easier. And the second reason is Faricimab. Faricimab is we've been waiting for quite a few years over the last, say, decade, since Eylea was launched, which is a treatment for age-related macular degeneration. We've been waiting for about 10 years for another breakthrough. And there's been a few false dawns, and we can touch on some of the treatments that have been coming through and may not have lived up to their expectations. So we've had a few of those false dawns, but Faricimab has now been launched in the UK. It's gone through regulatory approval, so now it's a licensed treatment. It's gone through the very robust NICE appraisal system, and it's been considered not only clinically effective but also cost effective for both the treatment of wet macular degeneration and diabetic macular edema. So for those two reasons, the Macular Society's support over the last few decades of trying to support eye health in the UK and the new agent Faricimab, I'm delighted to be able to speak to you this evening. So what I'm going to do is I'm going to cover a little bit about what age-related macular degeneration is and how it arises and why certain drugs can help it in certain ways. And then we're going to talk a little bit about what present treatments there are available, and then we're going to move on to Faricimab and explain where why we're so excited about it. So I'm going to talk a little bit on diabetic macular edema as well, but I'm going to primarily concentrate on AMD rather than switching between back and forth. But a lot of what I'm saying can be carried forward for diabetic macular edema as well. And I'm happy to take any questions at the end, specifically on any of those topics. So age-related macular degeneration. As many of you will know, in very simplistic terms, there are two common types. There's a dry and there's a wet form. And what the dry form is basically a gradual degeneration of cells at the back of the eye, which support the retina and keep sight going, certainly in the center of the vision known as the macula. So we're all prone to an element of dry macular degeneration as we get older. The back of the eye is a very metabolically active area, so there's continual turnover throughout every hour of the day. The cells are working and byproducts are produced. Now, those byproducts are sifted away by certain cells at the back of the eye, but they do build up year after year after year. So if we take, once you're above age of 60, 70, 80, there's a significant buildup of these byproducts, which we see, and we refer to these areas of accumulation, of degeneration, as drusen. And we see that in many, many patients. 30 to 50% of patients as we get older are going to experience this. But in a smaller proportion of those, we get a little inflammatory reaction occurs around these small little areas of byproduct production. And what that does is it produces a wound healing response. Now, if you think about it, if you cut your wrist, if you cut your skin in any way whatsoever, what happens is the area around where you've cut swells. And the reason it swells is because the body's recognized that there's something's wrong there and it tries to repair it. That's what wound healing repairing is. And what it does, there are certain chemical signals that cells will send out, and these cells send out these chemical signals saying, you've got to bring healing products here. We need you to help. We need you to heal this area. And effectively what happens is those chemical messengers, or so-called cytokines, cause blood vessels to leak. Now, the reason they do that is because if you're bringing in something to repair a tissue, it needs the thing has to get in and out through the cell wall. And so to be able to do that through blood vessels, it causes leakage. And so these chemical signals tell blood vessels to start leaking, and they also tell blood vessels to start growing to try and repair the area. And those two problems of leakage of blood vessels and growing of blood vessels are common both for age-related macular degeneration and for diabetic eye disease. And that swelling, these new blood vessel growth and the fluid leaking around is why we term the macular degeneration wet. And the wet basically is, as you've got all this leakage, sits within the retina. And if you think of it, the retina is an electrical circuit. The electrical circuit is sitting in puddles of fluid. And so what we've got to do is, one, prevent that happening in the first place. But once the fluid is accumulated, we have to dry that area up. And that's where really over the last 15 years, new treatments have been aimed at trying to stop this leakage of fluid, stop the blood vessels from growing. And one of the main chemical signals is a molecule called vascular endothelial growth factor. It's called VEGF or VEGF. And so what the drug companies have been trying to develop is agents that can block that molecule to stop the leakage. So that's where anti-VEGF has come from. And the first one that really came to light over about 15 years ago now was Lucentis, or Vabysmo was its generic name, but many of you will know it as Lucentis. And Lucentis overnight changed the prospects for patients with wet macular degeneration. Prior to that, we had very limited treatments. We'd had no treatment 5 years before that. And then in about 2001, we had some photodynamic therapy, which helped close the blood vessels, but they carried on leaking and scarring. So that didn't work. But Lucentis came on board around about 2007 and was able to stop these molecules and block these molecules from causing the leakage. And as I say, it revolutionized macular degeneration for patients. Now, unfortunately, what happens is it stops the leakage. It doesn't necessarily repair the damage that's already there. So it's critical that we get patients as early as possible before that fluid, the accumulation of fluid, has caused damage. And a lot of the work has been done over the last 10 to 15 years to explain to patients, to say, look, if you notice any new distortion in your eye, get it checked either by your optician or the local eye department, to look for identifying is there any new fluid there. Because if we get new fluid and we can stop that leakage, originally with Lucentis, then we can make a big difference in stabilizing vision for patients going forward. As I say, it's not that great at improving vision. Only maybe about 30%, less than a third of patients actually get a significant gain in vision. About 70 to 80% of patients get some stability, but only a small proportion of patients get an improvement. So the earlier we get patients, the more important. So Lucentis was the primary treatment for years, up to about 2000, from 2007 to about 2012, and then Eylea came on, a very similar product to Lucentis, but was more effective and allowed patients a slightly improved and slightly longer treatment interval. Because what these treatments are unfortunately, there's still an injection into the eye, an injection every month or every 2 months into patients' eyes to stop those blood vessels from leaking. Now, as I say, Lucentis was the first one, and that we felt that worked best when you were given monthly. Eylea, we were able to spread it out to maybe 6 or 8 weekly, so nearly 2 monthly. And that's been the state of play for the last 10 years. So for the last 10 years, the standard treatment for wet macular degeneration has been either Lucentis or predominantly Eylea, given into an injection into the eye every 2 months for year after year after year. And many of the patients we see in our clinics have been there 10, 12 years, having numerous injections to try and keep these the retina dry and these molecules from causing that leakage with these repeated injections. So we've got a growing population of patients who need injections every 2 months. And one of the things that we see is that as our population ages, there are more and more patients coming through presenting with wet macular degeneration and with diabetic macular edema. But as I say, if we talk about wet macular degeneration alone, there are about 35,000 to 40,000 patients a year present with this. Now that figure, it's very hard to get your head around. What does 35 to 40,000 patients a year? Well, what it means that in the space of this 1 hour webinar, there will be 5 new patients with wet macular degeneration in the UK alone. That's not worldwide. That's in the UK, 5 new patients developing wet macular degeneration who are going to need continual treatment for year after year to keep the vision. So as you can imagine, that's that growing number we have to try and address. How do we get patients in early? Remember, it's critical that we get patients in early. It's also critical that if the patient needs it every 2 months, they get it every 2 months. And with this growing number of patients, health services are stretched. How can we adapt to it? So there's a lot of interest in how can we get a treatment that would last longer than maybe 4 weeks or 8 weeks. What's the chance? What's the hope if we can extend that interval between the injections more? And that's what a lot of the interest has been. Now, that's where Faricimab has come on board. Now, Faricimab is a new product. It's the first of its kind. It's a so-called bispecific. And what that means is the molecule that we inject is an antibody into the eye, similar to Lucentis and Eylea, but it has 2 little arms on it. One arm is the vascular endothelial growth factor, same as Lucentis and Eylea. So it's got that. But in addition, it's got this other arm called anti-angiopoietin 2. So you've got 2 molecules for the price of 1, effectively. And that's where we believe its hope will lie. And so Faricimab was specifically developed with this so-called bispecific element, anti-VEGF, which is the Lucentis and Eylea style, plus this other one. Now, Faricimab has now gone through clinical trials. So whenever a drug comes to market, it goes through regulatory trials throughout the whole of the world. They run parallel studies, one in the US and some other countries, and one in the US and the rest of Europe. And there are these 2 parallel studies. And for wet macular degeneration, they were known as the Tenea and Lucerne trials. And so those were studied over 1,300 patients, and they studied Faricimab against the gold standard at the moment, which is Eylea. So Eylea is standardly given, you give it monthly for the first 3 months, and then you give it every 2 months. What happens with Faricimab in the study was that you had 4 injections initially to get you up and running and so-called loaded, and then patients were allowed to be extended to either from 2 months to 3 months to 4 months. And so the study reported last year on the first year results and has literally just reported earlier this year on the 2-year results. And what they found compared to the Eylea, now it was as good as Eylea in terms of keeping patients' vision and getting a small proportion of patients with improved vision. Remember, about 70 to 80% of patients, if we get you early enough, will be able to keep vision within the level that you present with. So Faricimab worked as well as Eylea at keeping that vision. But the strength of it was that about 70 to 80% of patients were on a 3-monthly, and about 50% of patients were on a 4-monthly injection. So now we've gone from a 2-monthly treatment to 50% of our patients getting out to 4-monthly injections. And 4 monthly injections is 3 times a year. So if we can now move the pendulum, instead of treating patients coming every month and then every 2 months, if we can now get patients with extended intervals out to 3 and 4 months, then that's a significant benefit. Not only for us as a health service being able to provide care, because if we can cut the number of times a patient visits, it means we free up slots to make sure that those visits occur accurately on time. It's no good me telling you, oh, come back and see me in 2 months, and then I send you an appointment for 3 months or 4 months. That's lost all the benefit of the treatment. So it's critical that when we give you an appointment, we have capacity to get you in. So any treatment that can extend the interval is a significant improvement. So from a health service perspective of trying to provide care for patients, it's a significant way forward. From a patient's perspective, what we hope you'll see is that will be a big difference. You'll be able to go, instead of coming every 4 weeks or every 1 month or every 2 months, you can now extend out to hopefully between 3 and 4 monthly intervals. As I say, over 2 years, it's somewhere in the region of between 80% of patients are at least 3 months, and about 50% of patients can get out to 4 months. And 3 times a year, although it's still an injection in the eye, which nobody particularly, I mean, patients tolerate it surprisingly well. It's always been, when Lucentis came on board about 15 years ago, really, as physicians, we thought, well, we're not sure how this will go. Will patients tolerate it? But patients tolerate it very, very well. One, because we've learned how to deliver it in an efficient and comfortable way, and a safe way, but also in the fact that it does work. It stabilizes the vision, it prevents vision loss and keeps people reading, driving, doing what they need to do. And so therefore, we've been able to reach that. And if we can do that with 3 injections per year, you can imagine that impact that's going to have. Now, obviously, the gold standard would be to have something that didn't need to be injected. It would be an eye drop. But many studies have looked at eye drops, and at the moment, we've been unsuccessful in developing something that works like that. We've got other agents that have been putting in an implant now, and we can talk about that in the questions at the end. But for the moment now, in 2022, we have this new drug, Faricimab, that's available. As I say, it's been licensed in the UK now for a couple of months. It's been through a very rigorous, nice appraisal system, which says, yes, not only is it effective, but it's cost effective. And now physicians in all eye hospitals, eye units throughout the UK will be ordering the drug in and being able to offer it to both new patients and patients on existing treatment. Now, that isn't to say if you are having existing treatment, you need to change. If you're stable and you're doing well on your present treatment, then, you have to question, do you want to, change to this new agent, or do you leave it a short while? But if patients are struggling on a treatment and having to come very regularly, then it certainly will be worth considering. And I think that many of patients who are already suffering with macular degeneration or wet macular degeneration, or having existing treatment, they will be having these discussions with your own eye specialist about, should I switch to this new treatment? For new patients coming in my unit, I see no reason not to consider it for new patients, because the evidence is there. We've seen the evidence in 1,300 patients worldwide about the benefits of it over existing treatment. And so therefore, I think there will be a swing towards treating with Faricimab, particularly over the next 12 months. Now, I've referred to it as Faricimab, because it's a little bit easier to say than Vabysmo or Vabysmo, and people will arrive exactly which word they're going to use. Vabysmo, just for your information, comes from it's VABYSMO, and that stands for VA for visual acuity. That's what we're measuring, vision. So visual acuity. BIS or BIS is for a bispecific antibody. So remember, it's got anti-VEGF and it's got this new molecule called anti-angiopoietin 2. So it's so-called bispecific. So you've got vision, bispecific, and MO means macular edema, which is fluid at the back of the eye. And so that's where the name Vabysmo comes from. I wish Roche had spent a little bit more money on marketing, because it's not a particularly great name, I don't think. I mean, I think Kathy referred to it. I'm not sure what Vabysmo means to most patients. Initially, when I heard it, I thought it was something to unblock drains. It sounded very, specific, like Silit Bang. It was that sort of approach. And then I thought, well, is it a Marvel hero or something? A new Vabysmo is going to save the world. But so I'm not particularly a lover of the name, but it will become common parlance, I'm sure, over the next year and 2 years, because it is probably going to become the primary treatment for most patients with wet macular degeneration. So Vabysmo or Faricimab, whichever you wish to use. And as I say, visual acuity, bispecific, macular edema, that tells you what we're trying to do. Keep the vision using this bispecific product, get rid of the fluid with the macular edema. And everything I've said pretty much stands the same for diabetic macular edema. We treat diabetic macular edema in a slightly different way of how we manage patients, but in essence, the problem is still fluid at the back of the eye, causing damage to this electrical circuit, the retina, sitting in fluid, to dry that area. And so these repeated injections, both with Lucentis and Eylea and now with Vabysmo, are becoming more, will be offered to more and more patients, really. And we hope that we'll be able to make a big difference for patients over the coming years. It's a very interesting time in the world of retina at the moment. There's lots of new treatments being trialed. Vabysmo, as I said, there's been a few false dawns of things that we thought was going to come to market and make a big difference, but certainly Vabysmo has certainly gone through that process, and we do believe it's going to have an effect. But I think the next 5 to 10 years, it is an exciting time of where we can help more and more patients in better ways by either increasing intervals or better outcomes for patients. But the key thing, as I said right at the beginning, is we must get patients in. So if you know of people, spread the message. The most important thing is, if you notice a sudden distortion in your vision, get seen straight away. The quickest and easiest way, effectively at the moment, is via a high street optician. I'm an eye specialist. We have an eye unit, 24 hours a day it's open. But in reality, for most places in the country, that you don't have that facility. But many places will have high street opticians who are highly trained. They're very attuned to picking up the early signs of wet macular degeneration. They have the equipment to do it. The OCT scan, which is the scan that we do to look for fluid in the back of the eye. Many high street opticians have this available now at very reasonable prices. Now, nobody, in these times of inflation, nobody wants to be paying anything. But I will be honest, you can go into Specsavers, and a scan in Specsavers is £10, which I was surprised at how they could even do that. But I had my own glasses check a few weeks ago at Asda, and they were offering an OCT scan for £8. And that OCT scan will be able to pick up macular edema early, and therefore allow you, hopefully, if we do unfortunately pick up wet macular degeneration, provide treatments, whichever treatment we're using at the time, but to provide it earlier. And the earlier we get patients, the better the outcome in the long term. So I've covered a lot of areas there and as I say, in this hour, there will be 5 patients afflicted with wet macular degeneration alone. So in this last 25 minutes, I've really tried to cover where the problem is, where we've been in the past, and where we are now in 2022, and giving you a slight taste of where we may be in the next few years going forward. So Kathy, over to you if you want to take some questions, and I'm very happy to answer as much as I can in the next 30 minutes.
That's brilliant. Thank you very much indeed, Ian. Yes, so if you do have any questions for Ian, please put them in the chat. I should have mentioned that earlier. Pop them in the chat, and we'll get through as many as we possibly can. So Ian, if I could just start off with a few things. We can't really underestimate the potential impact of Faricimab, because the pressure on eye clinics, particularly the medical retina, AMD, DMO clinics, has been huge, hasn't it? It's been enormous.
Yeah, I mean, I think many units are under a significant pressure, but I've been doing this for 20 years as a consultant. We've had a crisis every year. So I'll be honest, and it depends how you look at this. And you'll notice, and nowhere in my talk did I talk about a burden. And you'll hear lots of people talking about the burden of macular disease. It is not a burden. It is a condition that many of us face as we get older. And what it is, it's an opportunity for trying to keep patients with good vision. So I won't say we ban the word, but we don't talk about burden in our department specifically. And you'll hear many people talk about the burden of disease. It's not a burden, it's an opportunity, and it's fantastic that we've got treatments available. These treatments that we're offering are cost effective. So you'll hear lots of people talking about it's expensive, how do we provide it? Well, the treatments that we're talking about have gone through a very rigorous process of, is it, does it work? Is it safe? And is it cost effective? So Lucentis, Eylea and Faricimab have all been through NICE. Many other services in their National Health Service have not been through such a rigorous assessment to see whether it is cost effective. So it's cost effective. And yes, there are many numbers. But therefore, that's what we pay our taxes for, to actually support those services. And what we've got here is treatments that actually work and will continue working for many years, and keeping people both productive if they're working and productive in their retirement, in enjoying and doing the things that they wish to do. Now, how do we do that? Well, we have to think differently. We have to work collectively with community. We have to work with the Macular Society and other patient representative organisations to say, right, how can we better educate people? How can we identify and let patients know where the quickest and best way forward would be? The local optometrists, there are something like I can't remember the exact numbers, but there are something like, I think, 4,000 to 5,000 optometrists, high street practices around the UK. That's a fantastic asset. So what we're looking at is getting patients educated into optometrists and then refining the optometrist referral to us, so we get the right patients who we need to see. One of the fears when you've got a scanner in an optician's practice is that they're going to send everybody. And the problem is that that's okay, but 99 out of that 100 might not really need to be there. And the one wet macula might be right at the back of the queue of 100 people. So we've got to be very careful, but refining, educating, working with the local opticians to try and make sure we get the patients sent in appropriately. Those are all things that will help the demand and of the service. But as I say, it's not a burden. This is cost effective. It works. We just need to work at how we're going to provide that service. And as we've all seen in the last 2 years, money can be found when it's needed. And wet macular degeneration is a condition that is needed, because I'm looking forward to my retirement in 5 to 10 years time. I don't want to have my eyes affected without having treatments available for us. So there's a lot of, perverse incentives for us all to make sure that we move the boundaries forward. But it is a demand. It is I won't say crisis. It's an area we have to keep improving, but we mustn't, step off the pedal. And any agents like this will make a massive difference to us.
It really will. Now, please put your questions in the chat, but we do have people with their hands up. So I'm going to ask my glamorous assistant, Emma, in the background to, in fact, actually, I can do it. I'm going to go to Margaret first, and I'm going to allow you to talk, Margaret. Margaret Keogh, what's your question?
Hi, my question is, I have a BRVO,
yep,
and I am getting Avastin injections for that.
Yep.
4 weekly. My eyesight hasn't improved, it's distorted.
Yep.
And things look further away than they actually are. It's just one, and I just have I would more information on it.
That's fine.
Thank you.
So branch retinal vein occlusion is another big area. It's the same process. Branch retinal vein occlusion is a condition where the blood vessels supplying the eye and draining fluid from the eye get blocked. And it's almost as if you have a hose pipe and you stand on the hose pipe and you get this buildup of fluid and it bursts. And what happens is that vein occlusion refers to standing on the hose pipe. It's a blockage in a vein in the eye, and you get this fluid released. And so the fluid that you'll get with a branch retinal vein occlusion is very similar to the fluid in diabetes. It's the same fluid that you get in wet macular degeneration. It's the same process. And so all the treatments I've been talking about, Lucentis, Eylea, and now Faricimab, will all work effectively in branch retinal vein occlusion. Now, the Faricimab, we haven't specifically said about vein occlusions because it's not actually been licensed for that at the moment. It's going through trials, but Lucentis and Eylea have been licensed for branch retinal vein occlusion, and those agents are available and cost effective and approved by NICE. Faricimab are going through the trials, and we hope that that will be available. So I suspect it will be in the next 18 months, 2 years, who knows. So Faricimab would be available for branch retinal vein occlusion. Now, Avastin is very similar to Lucentis. It is the parent molecule of it. I'm not going to go into too much of the details about Avastin and where it lies in the treatment pathway, other than to say that we use a lot of it in Liverpool for many conditions, but we don't specifically use it for vein occlusions because Lucentis and Eylea, which have been approved and cost effective, we feel work very well. And there's possibly a little bit of evidence. There's a big UK trial done recently, which did show some benefit of Lucentis and Eylea over Avastin. But remember what I said to you about when we get you, all we can do at the moment is dry the retina. Okay, so if you think of this retina as an electrical circuit, all we're doing is drying it out. None of us, when we give those injections, know how well the retina will start working again. So if Avastin is drying you completely, then there's no reason to try a different drug, because if Avastin is working, Lucentis will dry it, Eylea will dry it, and Faricimab will dry it. They may last a bit longer, and that's something you could discuss with your physician. But in terms of improving your vision and getting rid of that distortion, it may be inbuilt in terms of if you dry it out, that may be, unfortunately, the damage that was done when the fluid was there. And this is why, again, getting patients in as soon as it happens so that we can dry it out as soon as possible is critically important. But certainly you can speak to your eye physician and say, you know, why am I on Avastin and not on some of the others? But if it's working at drying the retina, then the outcome will be the same. As I say, you might get a little bit increased duration with some of the other products, so it's worth considering that.
Yeah,
Margaret, thank you very much. I'm sorry, I'm going to have to move on, Margaret. I do beg your pardon. And we may have had a little bit of a problem with the chat at the start of the session, but it is now working now. So if you can pop any questions into the chat, that will make life a lot easier. So we've got a question here about another new drug and how it compares. So Beovu is another new drug that's just recently come into the market. This is another Novartis product. They make Lucentis, don't they? So how does Faricimab or Vabysmo, I'll try and call it, Vabysmo and Beovu, these are both the trade names, aren't they? How do they compare? So
they're different in terms of, so Beovu or brolucizumab, the product, they came out last year. It was approved, it was licensed for wet macular degeneration, and gone through the NICE approval process. So it has been available for over a year now, but it's very similar to Lucentis and Eylea in terms of it blocks VEGF. So it's an anti-VEGF-A molecule. So remember, it's only got one area. Now, it was better than Lucentis and Eylea in terms of you could get more. They made it very, very small, and they could get more of it in an individual injection. So that was the beauty of it, is that it would effectively be Lucentis, Eylea, but a bit stronger. Where it differs from Faricimab is the bispecific nature of Faricimab. Faricimab has the VEGF, but it also has this anti-angiopoietin too. So it's good, Beovu. It's very, very good at drying the retina, because you can get a lot of, you get a basically a lot of bang for your buck. It's small molecules, you can get a lot of it in there. And the reason we were really excited about was because it was very good at drying the retina out, because you got this extra molecule in. The problem was that in about 4 to 5% of patients, there was inflammation in the eye. And so that spooked many physicians. If the Hippocratic Oath is do no harm. So if I'm going to cause an inflammatory reaction in 1 in every 20 patients, then that initially, whereas all the other treatments I was giving, Eylea and Lucentis, are very, very safe. So that really has stopped it being used widely. That doesn't mean it shouldn't be used. It shouldn't. The issue is that we were hoping that was going to flood the market. It was a stronger molecule. It was going to work more effectively, but that's been balanced by this risk of inflammation in a small proportion of patients. So don't get me wrong. It's not, if you think 4% is a very low number, that means 96% of patients don't have any problem with it. So, but you can imagine that it's still put a little bit of doubt in physicians' mind. And so therefore it's not overtaken the market as we would have expected. However, for patients who are not responding to Lucentis or Eylea at all, and they're just not drying, it certainly will be worth considering. And that will be the same for Faricimab. If Faricimab doesn't work and it doesn't dry the retina, then Beovu would be an option as well. So it's on the table. It's probably not just going to be first line, but it's a very effective drug. But it hasn't lived up to what we expected it. And so the Faricimab, the Vabysmo, having this extra product, we believe will be a lot more durable and last longer for patients, and therefore reduce those intervals of injections.
Okay, thank you very much. So question here from somebody who is already on Eylea, but it isn't responding very well. So do you think Vabysmo would be a good thing to try, and is it likely to work better? And I think perhaps in answering this, you could pick up another question: is what is the magic property then of angiopoietin 2? What does that do then? And why is that why there is a possibility it might work differently for patients who other drugs are not working particularly well for?
I'll answer the latter part first. So remember I said to you, if you have what macular degeneration and diabetes to a certain extent is this wound healing response. So you get these chemicals released to say, come in and heal this area. And those chemicals are so-called cytokines, and one of them is VEGF. But there are other ones called angiopoietin, and there are 2 types. There's angiopoietin 1 and angiopoietin 2, and they work synergistically to try and heal but not overheal, and cause leakage but not too much leakage. And so angiopoietin and the molecule angiopoietin 2 is thought to cause leakage. So you've got VEGF and angiopoietin 2. So it's basically another chemical signal, but you're blocking it with Faricimab as well as the VEGF. Now, when patients and this issue of when you're not responding is a very complex issue for us as physicians, because actually, and there's a lot of confusion. There's confusion amongst physicians, so you can imagine there's confusion amongst patients. When somebody says they're not responding, it's critical to understand what they mean. Remember, what we're trying to do is dry the retina. If I give you an injection and it doesn't dry the retina, then you are a true non-responder. So whatever I'm giving you it's not working at all. That's a true non-responder. But there are other patients where we give the injection and the retina dries, but then it comes back very quickly, 4 weeks later. So they need another injection. And lots of people refer to those patients as non-responders, but they are responding. It's just that they're needing treatment more frequently, every 4 weeks. We refer to them, and I'm sure you've heard this term, as frequent flyers. Those are patients who are coming back every month. And they're different than the non-responders. So, because non-responders means what we're doing isn't doing anything. So if you're a non-responder and you're not having any effect, then yes, Faricimab may well work for you, but there's no guarantee. There's just no guarantee, because we don't know whether you weren't responding to the VEGF-A because you were already having that. So I don't know whether the extra Ang2 blockade will actually help you. But it's certainly worth trying. And those patients who are truly showing no response, we should try Faricimab. And if Faricimab doesn't work within a few injections, then we would try something else, and Beovu would be the next way forward, I think. If you're a so-called frequent flyer where you are having a response, you've got fluid, I give you an injection, it dries, but it comes back 4 weeks later, then it's very likely that faricimab will work. Now, I don't know whether, because you're already responding to the VEGF-A. Now, whether the ANG2 will slow down the recurrence of the fluid and mean that you can go from 4 weekly to every 6 week. You may not be one of those patients who are going to get out to every 16 months, but the chances are you're probably going to be longer than what you're on already. So a frequent flyer, if you're coming back on fluid, definitely worth trying. You're going to get a little bit extra duration. Hopefully, there's no guarantee because we haven't specifically studied that in the trials, but the expectation would be. But if you're non-responder completely, then it's more difficult, but I certainly would consider trying it. And many physicians around the country will try that. And there are certainly cases, it's been approved in the US now for over 6 months. So there are many cases who have struggled with all the other drugs and you put them on faricimab and they've dried. But everybody's great at showing their 1 or 2 patients. We've got to do it on 35,000. We've got to, it's no good just doing 1 or 2. We have to help as many as we can. So I don't know the answer to it, but I think we should try.
We have got loads and loads of questions, but I just want to clear up one thing, if you could, very, very briefly, Ian. Why do some people respond and other people don't?
We don't know that. That's a good question. We know that the VEGF works. Different patients have different levels of VEGF in their eye. So if you've got lots of VEGF in your eye, then blocking it's probably going to work. But if you're one of those patients who's only got a little bit, there may be something else that's driving the inflammation, driving the fluid. So that's the first thing. The second thing is if we get you late, then maybe there's already established damage. So if you come along late, the fluid has caused, the way I think of it and the way I tell patients in the clinic is it's like damp coming through a wall and you've got wallpaper there. Damp's coming through and it's rotting the wallpaper. If we get you early, then we can stop the damp every month. It means repeating it every month or every 2 months or every 4 months, giving that injection to stop the damp coming through. But the earlier I get you, the less wallpaper. So you might manage with that wallpaper a little bit worn out, but managing. But if you've left it or we've not treated it as well as we could, and that fluid has kept coming through, it just rots the wallpaper, and hence stopping that damp isn't going to stop that wallpaper from rotting away. And I know that's a very blunt way of putting it, but effectively is what's happening there. You've got to get it early, prevent its fibrosis or atrophy, that is the other major cause of it. But in essence, it's the wallpaper wearing out and with this continual damp coming through. So get it early, protect the wallpaper at the beginning. That's probably what's happening with the patients who are not responding, is they come late. And unfortunately, they've just, the damage is too far gone to really make a difference. That doesn't mean that we don't carry on treatment, because if we can slow down the progress, that might help significantly for patients. If we can keep patients managing with what vision they've got, then the longer the better. So we don't abandon, and it's always, we do when there's so much damage that really the risk of an injection, which is very rare, but the risk of the injection becomes more than the benefit. But those are very few cases that we actually give up on treatment.
Okay, that's great. A quick thing here about patient choice. Quite a lot of people are saying they're on one drug, it's not working, or they have to go quite frequently. To what extent is there actual patient choice here? Can you go to your ophthalmologist and say, look, I'm on Beovu, but I'd rather be on Faricimab, or I'm on Eylea, but I think I'd rather be on Vabysmo?
Physicians vary in many units, but most eye specialists, if you're seeing a consultant eye specialist, they've trained for a minimum of 10 years after they've qualified for medical school. So they're very, very experienced people. So although there may be ones who are slightly a bit more experienced in certain areas, the general level is extremely high. And medicine for thousands of years has relied on trust. You have to trust and believe in the physician. There is a patient, I think what's important is to raise it, because a physician, if we've got if we've got lots of patients coming through, the easiest thing is to keep you on the same drug. If I have to change you to another drug, then it takes time. I have to consent you, I have to go through, I have to write a new pathway for you. And so it takes time. So when you're in a busy clinic, it's very easy wanting you to get you in and out with the same drug. You're doing all right, we'll worry about it next time. So there is a bit of an incentive not to change. Okay. So I think by you asking and saying, oh, I know you're doing really, you know, we've been treating with this. I wonder, I've heard about Vabysmo. Do you think that will help me? And then it's very difficult. The physician then will go, oh yeah, well, I hadn't thought about that. It'll stop them. They'll not be an automatic no. So that would be my strategy of patient choices. You raise it, let them say why they would do it or why they wouldn't do. And then if you're not happy, raise it again the next month you're in. Okay, because I don't think you should always, there's a lot of times where we make decisions and patients think, oh no, that decision is forever. And it isn't. The way I treat patients now is 20 years ago is completely different. I've got lots of new drugs. So keep asking and saying, oh, I've heard about this. Why not that? And if they come out with a valid reason and saying, oh, well, I'm concerned about there's been a report of this or in your particular case. But I can't, for patients who are on 8-weekly Eylea doing very well, I'm not sure I would want to recommend switching at this stage, unless you were really struggling getting those 8-weekly appointments. I would say patients, I will be using it on patients who are new, because that's who the study showed that they work very well. So I'm comfortable with that. And then patients who are needing it very frequently or non-responding at all, I think they're equally good. So if you're coming 4, 5, 6 weekly for injections, I can't see any reason for really not trying it. Then there will be individual reasons, but they'll be small. If you're on 8 or 10 week or 12 week with Eylea, now you might say, well, I'd like to go to 16 week Faricimab, but you know, you're doing well on 8 to 10 to 12. So I wouldn't be in the first tranche of patients. I would say, no, hold fire. And that may be why a physician will say, no, you're doing okay. Let's stick with it. But you need to discuss that with your individual doctor, and they will, you know, hopefully. And if you don't trust them, then you shouldn't be. You should be with somebody else, because it doesn't work. It relies on trust.
Yeah, absolutely. If somebody does switch, will they have to go back and have the loading dose? Again.
We haven't studied switches in the trial, so the answer is we don't actually know whether you do need to go on a loading dose. I think many of us are thinking, if you're a non-responder, remember those ones who didn't dry at all, well, we'd probably load those and give them monthly for 4 months. If you're a frequent flyer and coming back at 4 weekly, 6 weekly, and we're going to try Faricimab, I'd be comfortable and going, well, okay, I'm going to try this. It's going to work. The study showed it worked as well as Eylea, so I'll give it you, bring you back in 6 weeks. If you're now dry, I'll then extend to 8 weeks, 10 weeks, 12 weeks. So we don't necessarily need to load a patient if you're just coming regularly, but you were responding. But if you've non-responded, then I think you should hit it as hard as you can. And if you're a new patient, we should hit it as hard as you can. But those are individual decisions where it's more about consensus. We really don't know what's safe and what's not safe. And many of us will just go, okay, let's just load, because then we know. Because if you don't load, you're always going to be thinking, oh, if I did load, would it have worked better? So just load at the beginning, take the pain at the beginning in terms of monthly visits. It's important if you're starting on a new drug to be monitored anyway. So coming back in 4 weeks is not a bad practice anyway. But that will be up to individual physicians and patients to make their mind. But my feeling would be, hit it hard. Generally, if you're a non-responder, possibly you could not load if you're doing reasonably well, 6 to 8 weekly.
That's great. A couple of people have raised the issue of being too good to treat. So this is a problem, isn't it, with all these drugs?
Yeah.
The trial evidence is only starts basically when people reach a certain level of vision loss. Actually, it's just sort of about the driving limit, isn't it?
Yeah.
And so patients are turned away because nowadays, because of OCT machines in optometry practices, clearly people are obviously being picked up a lot earlier.
Yep.
What do we say to these people who are too good to treat? It's awful.
So you're never too good to be treated. And there's this idea that, you know, oh, look, you've got 20/20 vision. Well, if you actually test the other eye of somebody who's got 20/20, sometimes they're better than 20/20, they're 20/10. So they're not good vision. They're actually, you know, 20/20, we think it's 6/6 vision, or 20/20 vision sounds good. But there are many patients who are actually above that. So the first thing I do is check their other eye. And actually, if they're above that, then they've already had a loss. They've probably had a loss of vision anyway, because otherwise, why are they with me? Why are they with the optician? I'm sure they've got better things to do on a Tuesday afternoon than turn up at my clinic. So there is something generally going on. And just because we can't measure it, when you go into the opticians and the eye specialists, you'll see the chart is a black and white chart. It's a high contrast. So you might read really well on a high contrast chart. And that would be great if the world was black and white. But the world isn't black and white. It's greys and it's light greys and it's shadows and it's depths and all those things we can't measure very well. So when a patient comes in and they say, I'm struggling, and I check their vision and their 20/20 vision, I don't go around to them and say, look, well, you're obviously wrong because you can see perfectly well. Well, no, they can't see perfectly well. They can read black and white reasonably well, but they can't measure shades and things. And so we don't put an upper limit on treatment. As I said right at the beginning, the sooner we get you, you do better. So if you're good vision, that's exactly where you want to do. If you're good vision, there's an 80 to 90% chance I'm going to keep you with great vision for the next 5 years. And that's where we want to. So we don't put an upper limit on that. There are some regulations around it, and because this is being recorded, I can't, but I think most physicians will treat patients with good vision with, there is a risk with every treatment. And so it has to be borne in mind. And also, just because we have to look at everything. It's, there are individual variations between patients. There are some wet macular degeneration which may not need treatment. It's very stable, so-called type 1 non-exudative. We're learning more and more about those. And what we do with those patients is we don't treat, but we watch closely, and we might see that patient in 4 to 6 weeks and monitor them very closely with the proviso that if they notice any sudden deterioration, to return immediately. But we don't, this idea of too good to treat, no. Everybody, the treatments work. Better to get you early, treat you when you've still got good vision.
That's great. Somebody asked about being treated if you have wet AMD in both eyes.
Yeah.
Going to the hospital, 1 week
Yeah.
for this, 1 week for that. Is it safe to treat people in both eyes on the same day?
Yes, is the answer, completely. So we've gone through this many years ago. So for the last 10 years, most eye units throughout the world will treat bilateral injections on the same day, as long as the patient's comfortable with it. Some patients know, they feel that that's just too much to come and have it both done on one, and that's fair enough. We respect the wishes. We try to encourage both at the same time, because then that does mean that otherwise you got to come back next week. So if you come in on 8 weekly and you come in twice for those 8 weekly, you're actually coming 12 times a year, which is is not great for you. So we will encourage bilateral. It is safe. Yes, there's a risk with every injection, but what we tend to do is we use a different batch of drug. We use a different kit for separating. So we mitigate for circumstances like that. And I'm not going to say that there can't be a problem, but most places throughout the world do bilateral injections. The only places that don't is certain areas where they'll only pay one. So if in Italy you can't have both eyes injected on the same day because the regulations say, oh no, we're only paying for one, and so they won't reimburse for the drug. So there are certain regulations around it, but in the UK we treat bilaterally, and most of the world.
Another question about another non-AMD DMO condition, so myopic maculopathy, so similar condition to wet AMD, but arising completely differently because of short-sightedness and damage to the eye caused by that. I guess this is a bit like the branch retinal vein occlusion question. Will it be available for myopia? And I guess, why do these sort of Cinderella conditions follow on? They sort of tail end Charlie for the approval of these new drugs.
Yeah, and the reason they are the tail end Charlie, as you describe it, is because the funding. These trials cost hundreds of millions of dollars, and I said there was a few false dawns. So companies spend hundreds of millions of dollars investing in these, and they don't know whether they're going to make them, whether it's going to meet the approval, be safe and effective. And so when they're setting out on the trials, they have to get investment, and age-related macular degeneration and diabetic macular edema are large groups of patients. So investors will go, oh well, yes, we'll put a bet on that. But myopic macular degeneration, there's thankfully fewer patients with that, and so they don't necessarily do their first regulatory trials. What they do is they start the trials off in macular degeneration and diabetes, and then these other, which are still critically important and likely to benefit, they start a little bit later because they make sure that their investment has worked before doing it. And that's just the way of the world. But there are trials, will be with Faricimab for myopic macular degeneration. And I suspect what normal happens, it comes on 2 or 3 years down the line. But we wouldn't be giving it you so-called off license at the moment for that. We would probably use Lucentis and Eylea, which work well. But when Faricimab trials come through for myopic macular degeneration, we'll then hopefully transfer patients onto it. But the other thing is to be sure about myopic macular degeneration, though. If you're 20-year-old and you've got myopic macular degeneration, that's true myopic macular degeneration. But if you're 70 and you're very short-sighted, you might have myopic macular degeneration, but you've got myopic macular degeneration plus probably some age-related disease as well. So for those patients, we will be happy to use Faricimab because it's effectively the age-related disease, even though you've got high myopia.
Quick one on the terminology, and this, somewhere along the line, we've created a muddle here in calling, we've got 2 types of macular degeneration: dry, age-related macular degeneration, dry and wet. Yeah. And yet when we talk about the wet disease, we talk about the drugs drying up the wet, yes, and making the eye dry. Does that mean, the question is, that the person now has dry macular degeneration? Sadly, it doesn't quite mean that, does it? No,
it doesn't. They've got wet macular degeneration, which is under control. So they've still got wet, because if you stop giving the treatments, they will then become wet again. So that's in theory what it is. So dry macular degeneration is it's not the retina that's dry, it's underneath the retina. The pigment epithelium wears out. And I think dry and wet will still, be around for many, many years, that terminology, because it's easy, it's simple. What's worrying is that some people talk about the dry being the good one and wet being the bad one. And that is not the case. There are many, many patients who have very advanced dry, who suffer significantly with loss of vision. And at the moment, as you know, for those advanced dry forms, we don't have treatments at the moment. However, there are treatments coming online. That the trials have gone through on certain drugs for that. And there's probably going to be a revolution in treating very advanced dry macular degeneration in the next 12 months, 18 months. We're not talking 5 to 10 years, as some people talk about. This is in the next 12 to 18 months. We're expecting and hoping that we'll have some treatments to slow down the advanced dry. But as I say, I think dry and wet are going to stay for the time being in those terminologies.
Yeah. Running out of time, sadly. Quick one here from somebody who unfortunately had been having 12 weekly injections, but they're now becoming more frequent 4 weekly. And why would that be? And we do know, don't we, that in some people the effects of the drug become less over time.
Yeah, we don't fully understand, but whether it's the condition itself, it's becoming scarred more and it's not leaking the same, or it's leaking differently, so it may be that. There's also the concept of what we call anaphylaxis, which is your body gets used to a drug and stops it being effective. So often switching to a different agent, you often do see an upturn in treatment. So I would have thought if you were on 12 weekly and you now need it 4 weekly, I'd check, make sure you're seeing somebody senior who's gone, right, well, why? Ask that question. Because when you're coming through the clinic in and out, sometimes that they don't sit down and think. If you ask, why have I gone from 12 to 4? Has something happened? That'll be the first thing. And then the second thing I would say is, okay, should I try a different drug? And it could be switching to Lucentis if you're on Eylea, or Eylea switching to Lucentis, or now try and switch into Faricimab. I certainly think that would be a fair question to ask your physician with that.
Yeah, that's lovely. Thank you very much indeed. Can I just ask you one last question, which is, what's your big hope for macular disease? If you looked ahead on the horizon, what's the big hope that you have for the future?
It's a very difficult question. That's a very hard question to answer. What I know is that for the last 10 years, wet macular degeneration treatment has pretty much stood still. We've had these all false starts and nothing's changed. I think the next 5 years will be a big difference. I think we've got Faricimab now. It's available now. You can go and have it tomorrow. But there are other agents that are in the pipeline which will be working more effectively. Remember, I said only about 30% of patients gain that vision. So get you early so that you're already good vision. But for those patients who present later, trying to get that improvement in the vision, instead of just being 30%, getting it to 50%, to 70%, to 80% gain in vision, that would be a big thing. I think moving away from injections is obviously, what many people want. We've got that already. If you live in the US, you can have the port delivery system, which is this little implant placed in your eye. We're doing trials in the UK on it, but that basically, instead of having an injection every month or through 2 months or 3 or 4 months, we're hoping that can be perhaps only topped up every 9 months. So you have a small procedure to put it in, and you top it up every 9 months. Now, those trials are ongoing. I was fortunate to do the first patient in the UK with the port delivery system, the first one in the UK, because we were doing it within trials. And so I think that is feasible for some patients that will have something that maybe just once a year for an injection. It would be nice to have an eye drop. I don't see that coming in the next 5 years. We are treating with genetic studies to try and produce VEGF in your eye. So we basically put a piece of genetic material that produces VEGF. We put that inside a virus. That virus gets injected into your eye. It gets taken up by your own cells. And basically you have this own factory producing VEGF, anti-VEGF in your eye. So that is, again, feasible. That's happening now. Patients in the world in clinical trials have had that. So I think that if you've got your own manufacturing of anti-VEGF to prevent it, if you've got implants that will mean you only need injections once a year, realistically, that's where I see the future in the 5 years. The things that I'd like to say about, we'll have a cure and we'll have an eye drop. I think anybody who says, that'll be 5 to 10 years means we don't know. There'll be any of your advisors on these webinars says, yes, we look forward to that in 5 to 10 years. Honestly, it could be, you might as well just bet on the lottery. But the things I've told you about tonight there are happening now and will be practical within the next 5 years. So I think you will, the future's looking better. I think make sure that we can be picked up early is the key thing. And I think the world is actually looking a lot rosier than it was 5 years ago. So I there's a long way to go, but I'm more optimistic. I was thinking of retiring a few years ago. Now I'm so excited about the treatments that we can offer patients. I'll probably stay another few years, really, I think. So I hope that's answered your question, Kathy.
It has, and thank you. We'll have you back to talk about the port delivery system as well on a future webinar, and if that's all right. To the person who has had AMD for some years but has not been able to see anybody about it recently, please go to your optometrist as soon as possible and ask for an appointment at the hospital. That's the best thing to do. Thank you very much, Ian. That's been a great session. I'm sorry we've actually overrun, which I normally say we are never allowed to do, but we have, and we still didn't manage to get everybody's questions in. But so I'm sorry about that. We will come back to a lot of these in future webinars, I'm quite sure. Now, next month, we're going to have another excellent speaker. I'm going to talk about something slightly different. We know that lots of people with AMD also have cataract, and we know that we get lots of calls from people wanting to know whether they should have their cataract surgery done or whether it might damage and exacerbate their AMD, or even asking whether having a cataract operation makes any difference in reality if you've got AMD as well. So next month's webinar, we will be entirely focused on having both cataract and AMD at the same time, all your questions answered. And my guest will be Professor Gary Mission, who is a consultant ophthalmologist in South Yorkshire and a professor of ophthalmology at Aston University, and he's a cataract specialist. So do join us then. Don't forget you can watch this video again online if you missed anything or you want to hear it again. And please signpost other people you think might be interested to our website or our YouTube channel so that they can look at our videos and our webinars as well. Ian, once again, thank you very much indeed, especially for giving up part of your holiday time. I'm so grateful to you. Have a great evening, and everybody else, thank you for joining us, and have a marvellous rest of your evening. Goodbye, everybody. Bye-bye.
Thank you very much, Kathy. Bye-bye now. Bye-bye.
Bye.